Our first speaker this evening is Dr. Prem Chahal, who is a gastroenterologist with Diablo Digestive Care. Welcome, Dr. Chahal.
Good evening. Thank you. Thanks for inviting me. I'd like to special thank you to Sandy Goldberg from Dazzle Valley Oncology for the invitation and this fabulous community center that I did not know existed until today, but it's amazing. Fantastic, guys. So I've got the honor of, I think, initiating or discussing the colorectal cancer, kind of the early screening, detection, and prevention modalities. My role, we each serve a role. Everyone on this panel serves a role in regards to colorectal cancer. The role of a gastroenterologist, which is what I am, is more about early detection and the initial parts of what we call staging, which is some of our next speakers will discuss more about. But my job is to assess an individual like yourselves and determine what the risks are based upon your family history, current symptoms, and then decide what the appropriate testing would be for that. And then if, in case something perhaps would be discovered, move you on to doctors like Dr. Joel and Dr. Woodman, who can further your care and take care of the issue, okay? The colon is the last 3 to 5 feet of your intestinal tract. It is, only job really is to reabsorb water, and it does so very, very well. It also does some mild things of salts and also vitamin absorption, but its main role is to reabsorb water. It's our social organ, and so without it, we're not as social. That being said,
I think it does.
I don't know if we can
Sarah, do we have a laser pointer on this?
I apologize right now. As you see, my slides are a little bit too busy on there. I thought we may have had a bigger screen, but I will cut it down to the easy versions. The colon actually starts on the right side, and that's where your appendix comes off. That's the initial point of the colon. That's called the cecum, and it extends all the way back until it exits out into the world in the rectum.
There is no laser.
There's no laser. That's okay. The typical cancer that we will see in the large intestine is called an adenocarcinoma, which I believe Dr. Joel will explain a little bit more in detail. Colorectal cancer, it's the 3rd leading cancer in the United States right now. It's for both men and women who have equal rates of developing this colorectal cancer. Breast cancer and lung cancer are still number 1 and 2, but colon cancer, as we are all living longer, is becoming more and more of an issue. Colorectal cancer and prostate cancers are the 2 cancers I always tell my patients, they're diseases of age progression. We don't see colorectal cancer in individuals, well, not as much in their 20s, but as every decade goes on, the incidence starts to increase. And that is why...
Do you have one at the middle button?
I don't think we'll work on that. Oh, that's okay. Thank you. The key to any cancers, the key to any and every cancer is early detection. Why is that? Easier treatments and higher survival rates, which we'll get into a little bit more. More than 1/3 of colorectal cancer deaths can be avoided if individuals come in and get appropriately screened. And we'll kind of discuss about what the screening guidelines are. And we'll talk a little bit more about colorectal cancer screening and how we utilize it. It is safe, it's effective, and I'll show you some of the numbers in regards to that. Dr. Uman, you want to join us?
There's a seat for you right up here.
Initially, when you see your primary care physician or a physician like myself, the questions we're going to inquire about are what we call alarm signs. These are symptoms that alert us that maybe something else is going on that we need to explore a little bit more. Rectal bleeding, that's one of the first things, especially in men or women, but men predominantly, when we see rectal bleeding, we get a little bit more concerned, simply that women tend to have more hemorrhoidal issues than men do, generally speaking, because of pregnancies, etc. But for both men and women, rectal bleeding is one of those things that we're going to be very keen on. Your physician might order a stool study called a fecal occult blood test. If that returns positive, that's another indication to kind of pursue a further evaluation. Change in bowel movements. The critical thing is if your bowel movements change, either you get new onset constipation where you're straining to have bowel movements, or you have thin stools. If the stools are getting thin, that might imply that something is obstructing the outway of the colon, and we need to evaluate that a little bit more closely. If you get discomfort with bowel movements, or you have an urge to go but simply can't have one, maybe that implies there's something else that's causing pressure in the intestinal tract. If you have frequent cramping pain or gas pains, weight loss, that's one of those classic B symptoms. We call those where people, these are vague symptoms that you can't put a finger on, but something else is going on. So if somebody is losing weight, it kind of gets our ears perked that we need to find out why that's happening. And if you're constantly fatigued, yet another symptom to look at. I don't think I'll do that.
Okay.
Sorry, really small print. But screening guidelines have been established by every cancer society, the American Cancer Institute, the AGA, etc. But these guidelines have been designed to assist us and figure out who needs to be screened. Now, everybody in the United States is urged to get their initial screening at the age of 50, and that's for an average risk individual. However, there are certain individuals that we view are an increased risk because of their history or a family history. So if you have a personal history of colorectal cancer or polyps, we want to see you a little bit earlier. If you have a family history of one or more parents, siblings, or first-degree relations, you get a colonoscopy or some evaluation at the age of 40, or 10 years before the onset of your affected individual. So if your father had developed colorectal cancer possibly at the age of 45, we'd recommend you come in at 35 for your first evaluation. If you have multiple cancers, inflammatory bowel disease, I see a lot of patients with ulcerative colitis or Crohn's disease. Those individuals that are higher risk, we need to bring them in a little sooner to take an evaluation. There are certain syndromes that I won't touch upon too much, but these are syndromes that cause a lot of polyps to be formed. One is called Lynch syndrome, another one's called familial adenomatous polyposis, FAP, and these individuals get colon cancer at younger ages, so we need to see them and be very aggressive with their care. But the initial screening guidelines is for the age of 50 for everybody in the U.S. The one exception, besides the family history or personal history, is the African American individuals. Now, this is a guideline change that's occurred in the last 2 years. Prior, it was all, but what they've done is they've looked at African American individuals and all ethnicities across the board, and they found that this subgroup is at a much higher risk of colorectal cancer. They're diagnosed. Sorry. We lost it. Oh, there it is. They have a higher incidence and a higher death rate associated with colorectal cancer. One of the issues may be that there might be what we call biased data. Biased data means that it's not an equal playing field. Equal playing field implying that what is the one group of individuals that do not get screened as frequently as other subgroups, and those are African American individuals, particularly men, and so they have a higher rate of colorectal cancer. So that might be some influence on this data. Interestingly, there's a study that came out just this year in 2014. It was called the SEER study, the Surveillance, Epidemiology, and End Results Study, and they looked at colorectal cancers in different age groups. And what they found, based upon our current age progression and the way colorectal cancer is proceeding, the largest increase in colorectal cancer will actually occur in individuals 20 to 34 years old. And in 10 years or 20 years, there's going to be a 124% increased risk in these individuals. Still small, but it's starting to increase. So I predict in the future the guidelines will continue to evolve and incorporate more of these individuals. And it's really due to obesity. Our problems in the United States are due to obesity and inactivity. We're finding out that that might be contributing to polyp formation. So what are polyps? This is the line. If I say nothing else, this is it. All colon cancer comes from polyps. Very few polyps will ever become colon cancer. So, and that's important. What are polyps? Polyps are akin to skin tags. Think of skin tags on your skin, but they grow in your large intestine. And these are the things that, as a gastroenterologist, I am looking for. This is all colon cancer, as it derives from polyps, will eventually, if allowed to grow, will continue to get bigger and bigger and bigger, and eventually can become colon cancer. What we know about polyps is that about 24% of us will have them. This was data from 1996 from the government. What we also know about polyps is most of them are less than 1 centimeter, and that's important because polyps less than 1 centimeter, well, 99.7% of them are not cancerous. But if they're allowed to grow, and as you can see, the one on the right gets bigger and bigger, once they get to 2 centimeters, almost 30 to 50% of those become cancer. So that is why colon cancer is one of the few cancers that's almost completely preventable because of polyps. Because if we can find these polyps when they're small and get rid of them and prevent them from ever growing up to become anything bigger, we can prevent, hopefully, colon cancer down the line. On the pictures on the right, these are typical polyps that we would see. The one on the upper left is a polyp that's probably about 5 millimeters in size. The one on the right has got a little stalk on it, and that's closer to about a little over a centimeter, probably 1.2 centimeters. So this is more concerning, of course, on the right. There on the lower left is what we call a flat polyp. These polyps grow kind of on a flat surface, kind of hard to see. This is why your doctor will continue to tell you, please do the bowel preparation, because if there's a lot of stool in there, liquid, it'll be difficult to see, especially the one on the right. And that's called a flat polyp. You can barely see that. It's just kind of like a little shade growing on the side of the surface, and you need a clean colon to find these. The flat polyps on the right are these are the ones that studies have shown have a high potential of becoming colon cancer down the line. So, we're not going to go through all that. But the key thing for early detection is there are several studies that are out there that some of them your primary doctor will do, and other ones will be specialists will perform. The ones that we'll see often done in the office are stool studies. Now, stool studies include a fecal occult blood test, a FIT test, and a stool DNA. But the key thing about all the stool studies, they are not designed to check for polyps. So this is not for early detection of polyps. What they are designed for are early detection of cancer. And the reason for that is blood in the stool is a late finding as far as polyps are concerned, and for early finding for cancer. So the stool studies, if they're checking your stool for blood, what they're really looking for is early indications that something is bleeding, and that usually implies the polyp or it's already developed into a cancer. As far as prevention is concerned, that gives us a signal, but the whole goal of what I do is to prevent colon cancer. And this study does not prevent colon cancer. What it does, it tells us that there's something to worry about, and we need to go find out what that is. But the stool studies, the fecal occult blood that your doctors do in the office, they're safe, they're effective, they are influenced by food that you eat. So that's one thing to consider when you do this study. Things like vitamin C, red meat, radishes affect your stool study, the fecal occult blood test. So that's one thing to consider, and you always should give 3 samples. It increases your sample size. Then a new study has come over, and which I suspect in the next year or two will surpass fecal occult blood testing. It's also a stool study, but it's called a FIT study. And now the FIT it detects blood with higher accuracy, and it's not influenced by things you eat. It's also inexpensive, and it requires no preparation. So I expect this study will then take over most of those fecal occult studies down the road. Now, as far as other detections, with imaging, there are some other things that we can do. This is what we call a barium enema. This is an X-ray study. Most people do not like this study at all. The reason is they put contrast in your bottom and they shake you around and they put air in there. Not comfortable for most people. So it is still an approved modality for individuals starting at the age of 50, only for average risk individuals, and it's good for 5 years. The problem with barium enemas is that it's not very sensitive, meaning they don't find polyps that are really small. They won't find flat polyps at all. It only finds polyps about 1 to 2 centimeters in size. A new study that got a lot of interest early on was CT scans. So it was basically CT colonography. This study, and that's exactly how a picture would look in a CT scan. What they do is you do a preparation like you do for a colonoscopy. They do a CT scan, and a computer reconstructs it into a cartoon. And what basically the radiologist flies through your intestinal tract, looking at the colon and for polyps. The problem with the CT scan is that it was just as accurate as a colonoscopy. The problem was that cost. So about, like I mentioned, 24% of us will have polyps. Well, guess what? If they have a polyp, CT scan can't get rid of the polyps. So your doctor is going to refer you for a colonoscopy. And Medicare said, we can't pay for a test twice for 25% of the population. So they said they didn't approve it. And as soon as they didn't approve it, none of the other insurances approved it behind it. So you kind of have to pay for this one out of pocket. Flexible sigmoidoscopies. I don't know how many members here are Kaiser members, but this is what Kaiser does a lot of. And what the flexible sigmoidoscopy advances an endoscope from your bottom to the left side of the colon. It doesn't, the problem with the FlexSig is it doesn't look at the entire colon. Remember, the whole goal of what I do and what we do here is early detection and remove the risk of colorectal cancer. Unfortunately, the flexible sigmoidoscopy, by not looking at what we call the right side of the colon, is not a complete study, and therefore it misses right-sided lesions where potentially other polyps could exist. It is inexpensive, relatively speaking, and a lot of parts of the country where they can't do colonoscopy because they don't have personnel or facilities, a lot of doctors do this in their office. Usually FlexSig should be combined with some kind of stool study for kind of reassurance. Lastly, the colonoscopy. Upper right is what we used to do before technology. Nowadays, we've gotten a little bit better. Not much, but a little. Colonoscopy right now is the gold standard for colon cancer evaluation. The reason for it is it's the only study that is diagnostic and therapeutic. Diagnostic meaning that we're looking through the entire colon from the rectum to the appendix or cecum, and it's therapeutic. We take those polyps off at the same time. So Dr. Umit and I will do these evaluations, and we get, not only can we tell our patients that it was a complete exam and they're fine, but we can get these polyps out of there and then determine what your risk is in the future by the findings on those polyps. But it's a sedated procedure, and so you will not feel any discomfort or pain, but it does require preparation, and it does have slightly higher risk and cost associated relative to the flexible sigmoidoscopy. How do we reduce risk in regards to colorectal cancer? I do believe this is my last slide, but generally speaking, we don't have a clear-cut idea of how to reduce the risk of colorectal cancer. There's no magic dietary formulation. The only study that was ever done looked at aspirin, and aspirin does show some benefit in reducing the formation of polyps, but the study also showed you need to be on it every day for 10 years. So I don't know, we're not indicating that right now. But what we do know and we think is that the longer toxins stay in your colon, i.e. stool stays in your colon, the more chances it can influence the cells around it and cause changes that might become more problematic. So in that regard, we recommend eating more foods that are higher in fiber, whole grains, fruits, and vegetables. In regards to vegetables, they found that cabbage, broccoli, cauliflower, and Brussels sprouts have an added advantage, and I can't tell you why that is, but that's what studies have shown. You want to increase your calcium intake, milk, shellfish, and salmon, decrease fats, oils, butters, and red meats. Limit your intake of charcoal broiled foods. It's an interesting study, and a side note, that there was thought that more men were getting cancer than women, and so they said, well, what do men do that women don't? Well, we eat more barbecued red meats. They said, aha, that's it, it's barbecued red meats. So they did a study about polyps between men with barbecued more red meats and vegetarians, and they found the vegetarians had more polyps. So, take it for what it's worth. Exercise regularly, do all the things that your doctor always tells you to do, don't smoke, and you want to keep your body mass index in a range that is healthy. The more body mass we carry, the more problems it'll be overall.